we'd like to talk about non-tubal ectopic pregnancies, which are on rise nowadays because of increased rate of cesarean sections and also artificial reproductive technologies. Most of the ectopic pregnancies, 97%, are tubal ectopic pregnancies. Non-tubal ectopic pregnancies are rare. They are often misdiagnosed and overlooked with an incidence of 5 to 8.3%. Risk factors are more of the same as a tubal ectopic pregnancies. These are the various sites where non-tubal ectopic pregnancies can occur. They may present with simple pelvic pain and vaginal bleeding, or they may present in shock, or maybe completely asymptomatic also. So this is a case of interstitial ectopic pregnancy. This incidence is of 2 to 4% of all ectopic pregnancies, and pre-episiotomy salpingectomy is a main risk factor. And because of its greater capacity to expand, it may present late with a rupture with a catastrophic severe hemorrhage. So ultrasound criteria, this is E is ectopic and U is uterus. In between the ectopic and uterus, there is an interstitial line sign. So identification of echogenic line between the gestational sac and the endometrial cavity with eccentrically located gestational sac with myometrial thickness less than 5 mm. It is ultrasound criteria. So if the patient is stable with less than 3.5 centimeters mass and less beta HCG with absent cardiac activity, we can manage expectantly. Otherwise, in unruptured ectopic, systemic or local methotrexate have been tried, and single dose methotrexate can be tried without cardiac activity less than 5000 international units. If the beta HCG is greater than 5000 milli-international units, multiple doses should be given. So before giving methotrexate, we should look for complete dead picture, LFTs and RFTs. So after giving the single dose, we should look after 4 to 7 days. If there is a fall in 15% of the beta HCG, greater than 15% of beta HCG fall is there, then there is no need to give a second dose. Otherwise, we have to give a second dose. And if beta HCG is greater than 5000 international units, then we have to follow a fixed multi-dose regimen. So these are all the contraindications to the methotrexate therapy. So nowadays, systemic methotrexate can be combination with a gefitinib, that is oral epidermal growth factor receptor inhibitor, may be an alternative therapy. In presence of cardiac activity, potassium chloride should be given under ultrasound guidance into the fetal heart. So surgical therapy, this is a U is uterus, R is round ligament. This is a resected picture. Corneal resection or laparoscopic corneotomy is a surgical method. Intraoperatively, intramyometrial vasopressin at a cornea will limit the surgical blood loss. So uterine artery embolization is also tried before the surgical procedure if the patient is stable. And if if he is torrential bleeding, then we should go for hysterectomy. Future pregnancy should be managed by cesarean section near term. So angular pregnancies are normal pregnancies, but they are eccentrically implanted near the conva. They have the miscarriage risk and abnormal placentation or rupture risk. They should be managed as normal pregnancies with caution. So another entity is rudimentary horn pregnancy. The H is horn rear and O is ovary and U is uterus. This is a ruptured rudimentary horn pregnancy presented at 12 weeks of gestation with the twins. And it has an incidence of 0.2 to 2% of ectopics, and horn has a capability of some hypertrophy. So usually they present with a rupture in second trimester. So there is ultrasound criteria for corneal pregnancy also. A single interstitial portion of fallopian tube in the main uterine body should be present, and mobile gestation sac surrounded by myometrium and separate from the uterus should be there, with gestation sac adjoining to the unicornate uterus with a vascular pedicle. These are the ultrasound criteria. So methotrexate is ineffective and surgery is the treatment choice, and excision of the rudimentary horn, this RH is an excised specimen of the rudimentary horn, and 50% of the cases presents with the placenta increta. The second picture shows V is villi. Villi invading into the M is myometrium. So villus is invading into the myometrium in a 50% of cases. So next is the ovarian pregnancy. Ovarian ovarian pregnancy is rare with a 3% of incidence, and the signs and symptoms are similar to other type of ectopics, and difficulty in preoperative diagnosis is there. Corpus luteum can mimic the ovarian ectopic pregnancy, but confirmation is only by histopathology. Identification of separate corpus luteum is helpful during the surgery. So Spielberg criteria is for ovarian ectopic, then ipsilateral tube must be intact and distinctly separate from the ovary. The gestation sac should occupy the place of the ovary and it is attached to the uterus by the ovarian ligament. So ovarian tissue should be demonstrated histologically between the placental tissue as shown in the picture. So management is only mainly by surgery, there is no medical management. So wedge resection can be tried, or partial or total oophorectomy can be done. Methotrexate only for persistent trophoblastic tissue after laparoscopy. So cervical ectopic is a rare ectopic, less than 1% incidence. So it is implanted in the cervical tissue. Rubin's criteria is anatomical and histological criteria. Cervical glands must be opposite to the placental attachment, and the placental attachment should be below the internal os or below the level of the uterine vessels or peritoneal deflections. Fetal element should be absent in the uterus, but this requires a hysterectomy specimen. So clinical diagnostic criteria was given by Coleman et al. So these are hourglass appearance of the uterus and products of conception entirely confined to the cervix, closed internal os and a slightly open external os. So Raskin ultrasound criteria modified by Timmer-Trich. This is hourglass appearance, same. Uterus is enlarged and ectopic cervix is also enlarged, dilated, barrel shape, and products of conception located below the internal os with the empty uterus. Djokovic's criteria, that is sliding sign which is present in normal abortion on TVS must be absent in cervical ectopic cases, and demonstration of peritropoblastic blood tissue also be present in cervical ectopic. Treatment is mainly expectant if the patient is stable. If she is not stable, conservative surgical treatments are proposed like dilatation curettage followed by Foley's catheterization or cervical surclass, uterine artery embolization, and hysteroscopic resection also tried in some cases. So coming to cesarean scar ectopic, these are very rising because of increased rate of cesarean sections nowadays, and the previous history of cesarean section with the less pregnancy interval is a risk factor for this one. So ultrasound criteria, empty endocervical canal with the gestational sac anterior part of the isthmus. So myometrial thickness should be less than 5 mm. So there are two types of cesarean scar ectopics. One is endogenous type, another is exogenous type. Endogenous type progress towards the endometrial cavity, so it may progress into second or third trimester. But exogenous type, type 2, it is grow towards the abdominal cavity. So early rupture in the first trimester itself into the bladder is there in an exogenic type. So the relation is explained by this crossover sign. What is this crossover sign? The gestation sac greater than 2/3 of the gestation sac is above the endometrial line, then it is called cos 1. If 2/3 of the gestation sac is not above the endometrial line, then it is cos 2. Why it is important to know this means cos 1 will rupture in the first trimester itself because it will go into the abdominal cavity, towards the abdominal cavity. Cos 2 is endogenous and it will go towards the endometrium. So management is, it can be by direct methotrexate injection by villus needle as shown in the picture, or hysteroscopic resection or uterine artery embolization. DNC with Foley's catheter insertion has a risk of rupture and severe torrential hemorrhage. So abdominal excision as shown in the picture can be tried when rupture happens, and it has a placenta accreta risk of 75% as shown in the picture. Villi is invading into the myometrium. And so while counseling the patient, if she is cos 2, then we can counsel regarding placenta accreta and continuation of pregnancy. But if she is cos 1, we have to terminate the pregnancy because it has a greater chance of risk in the first trimester itself. It is from this lecture. So abdominal pregnancies are another entity which is very rare, but malformed uterus is the most common, and with the oligohydramnias and the difficulty diagnosing is the ultrasound finding in the abdominal pregnancy. So we have to leave the placenta in situ if it is attached to the vital organs. Intraligamentary pregnancy is present between the two leaflets of broad ligament. It is also very rare type of ectopic pregnancy. And after hysterectomy also very rarely ectopic pregnancies can occur. But because these are early presentations or because of unrecognized pregnancies, but late presentations because of vaginal tubal or vaginal peritoneal fistulas. So they follow mostly vaginal hysterectomies. So conclusion is non-tubal pregnancies is a challenge, but all of the non-tubal pregnancies have ultrasound criteria nowadays, and we can diagnose easily early. So this is essential for fertility loss, avoiding the fertility loss of the patient. Thank you for giving me this opportunity to share my knowledge and my experience. Thank you, ma'am. Thank you, organizers.